Hi and welcome to the back pain and red flags to treatment, what not to miss. As you all know, red flags are vitally important, and this is trying to give you as much information regarding two particular serious pathologies to make your treatments ultimately safe. Now, to put your mind at rest, serious pathology is seen in less than 1% of all back pain cases. But essentially what we want you to do is be screening the patient for the serious pathology, whereas you pretty much know that it's a very small amount or minute amount of the population that will have it. But if you're not looking for it, you will miss it. It's important to identify those cases to refer them to the relevant specialist as early as possible. Now, this will determine what type of practitioner you are and whether you have direct or indirect access to the medical profession. If you have direct access, then you'll be able to specifically refer to a particular medical practitioner. If it's indirect, then what will happen is you refer through the designated pathway straight back to the GP, if necessary, who will then designate the specialist that the patient should go to. Or if it's extremely serious and falling under the red flag, then they should be going to the A&E, accident and emergency, critical care, or the ER, whichever you may call it. So overall, you should be identifying the red flags during your case history, and we'll be talking about how you do that, and in particular, as I said, two relevant red flags. Those two relevant red flags for this lecture are cauda equina and metastatic spinal cord compression, or MSCC for short. Their two areas are considered emergency conditions, should be seen by the relevant practitioner as soon as possible. And unfortunately, as you'll see through this lecture, there is a little bit of grey area in what the red flags are, what stages that they're at, and ultimately, there are so many tests that you can do. We want you to find the test that is appropriate for you. Remembering case history is the most important. Whether that's subjective, objective, make sure it designates what your plan is to get a structured routine to identify for these red flags. You need a systematic approach to your examination. Now, everyone has different tests that they like to do, and every practitioner is different. You need to find which tests that you can reproduce, which have good efficacy scores and reproducibility scores, and there are so many out there. So once you finish this lecture, it's always a good idea to revisit those tests, see which ones that you like to do, see which ones you haven't done for a while, for whatever reason that may be, and it's always good to refresh. Make sure you have a clear, thorough understanding of the patient's symptoms, getting your perspective, and also educating the patient as to what you think may be causing their problem. Hopefully, you're sitting there right now saying, well, yes, I do all of this. When that's great, then you're doing the right thing and you're absolutely on the right track. Keep it organized, keep it comprehensive, and as I said, keep it reproducible. You need to cater and make sure you are understanding a wide variety of testing and a wide variety of conditions that will keep you a good, rounded practitioner. Here is a brief rundown of your musculoskeletal assessment or your case history. And again, if you're looking at this saying, this is what I do, then yes, correct. But overall, not everybody does this in the same way. Everyone has their own way, and this is just a rundown. Patient history is covering date of birth, full name, any medical conditions that they know they have. You're also talking about medications because they will also come into this. Observation, that starts actually before you've even asked the question, when they're in the waiting area and you're greeting them in, making sure that you're observing any gait issues or any grimaces of pain, anything that is out of the ordinary. Now, the examination to movement is a vast array of different things that you can do. Okay, you need to make sure that again that it's structured for you and you have clear reproducibility lines. Same as special tests, reflexes, cutaneous distributions, joint play, and palpation. Now, not all of you will have diagnostic imaging on your front door, especially if you have only indirect access. So you can potentially, depending on the country, and self-refer the patient directly to for potentially an ultrasound or MRI, but you should only be doing these if relevant. And remember, do some research behind joint imaging and diagnostic imaging, because not necessarily what comes up necessarily is the problem. So these can result in a lot of asymptomatic findings, which can have positive and benefits effects, and also can mislead what you think is actually the problem at that time. That brings us to the end to the introduction. You can now move on to section 2.